It's so good to see everybody in person. I'm excited that the panel is all here in person. I'm Lynn Zajdowski. I'm the Chief of Science for Alexandria Real Estate Equities and Alexandria Venture Investments. A big thank you to the Galien Forum, to our co-chairs, Mike Rosenblatt and Sue Desmond-Hellman, and a special thank you to Roy Vagelos. It is truly great to be here today with everyone in person. Our panel today, the title is Combating the Opioid Crises in America. And as many of you may know, the opioid epidemic has been one of the most pervasive public health challenges in our nation's history, and it remains one that shows no signs of abating. Between 1999 and 2019, nearly 500,000 lives were lost in the U.S. due to opioid overdose. And while we continue to emerge from the COVID-19 pandemic, which has been made possible by the unprecedented rapid development of vaccines and therapeutics and diagnostics, the opioid crisis persists, and it's exacerbated by the social isolation measures that were put in place to control the spread of the virus. The COVID-19 pandemic has had a devastating impact on addiction, mental health, through stress, uncertainty, isolation, and economic hardship. Overdoses claimed a staggering 96,000 lives during the 12 months ending March 2021, which reflects a 30% increase since March 2020. And although the number of suicides remains obscured within the number of overdose deaths, federal health agencies acknowledge the long-established comorbidity of substance abuse, use, and mental health disorders, estimating about half or 50% of those who experience mental illness during their lives will also experience a substance use disorder. We need to change the perception of mental health and substance abuse, and we call upon our nation and all of you here today in the room, listening virtually, to increase its support and funding around the deadly and costly opioid crises. The life science industry has demonstrated it can radically and positively impact society, and it's imperative that we work together to actively support, incentivize, and innovate a path forward to solve the worst drug crises in our nation's history. Our panelists today are committed to advancing effective, scalable solutions and to shaping policy to combat this highly complex public health crisis. And today we'll hear more about their innovative and holistic solutions that are essential to the comprehensive undertaking required for meaningful change and to revolutionize the way addiction is understood and treated. So with that, I'd like to introduce our esteemed panelists. To my left, I have the Honorable Patrick Kennedy, a former U.S. Representative, the founder of the Kennedy Forum, former member of the President's Commission on Combating Drug Addiction and Opioid Crises, and a co-founder of One Mind and a co-chair of Mental Health for Us. In 1994, Patrick was elected as a Democrat to represent Rhode Island's 1st Congressional District. He was reelected 7 times, serving from January 3rd, 1995 to 2011. During his time in Congress, he was the lead author of the landmark Mental Health Parity and Addiction Equity Act, better known as the Federal Parity Law, which requires that insurers and employers cover treatment for mental health and substance use disorders no more restrictively than treatment for illnesses of the body. It was passed into law in 2008 during the Bush administration. In 2015, he co-authored a New York Times bestseller, A Common Struggle, which tells his deeply personal story and details a bold plan for the future of mental health care in America. As founder of the Kennedy Forum, he now unites advocates, policymakers, and business leaders to advance evidence-based practices and policies in mental health and addiction. And in 2017, he was appointed to the President's Commission on Combating Drug Addiction and Opioid Crises. He currently serves as the co-chair of the National Action Alliance for Suicide Prevention's Mental Health and Suicide Prevention national response to COVID-19, and he's a co-chair of the Bipartisan Policy Center's Behavioral Health Integration Task Force. Next to Patrick, I have Marty Taylor, who's the president and CEO of 115. She started her career in 1986 after graduating from Capital University in Columbus, Ohio, with a BS in nursing. She began as a staff nurse in the cardiac intensive care unit at Duke University, and during that time went on to graduate from Duke with a Master of Science in Nursing. It was during her 25-plus years at Duke that she fell in love with academics, research, teaching, clinical care, and mentorship to others. While at Duke, she supervised all aspects of the health system's heart center at 3 hospitals and multiple affiliate hospitals. Most recently, she served as the chief executive officer of University Hospital at the Ohio State University Wexner Medical Center, and in that role, she was responsible for leading more than 5,000 employees and a budget totaling more than $1.8 billion. Today, she's the CEO, and she's the CEO of 115 and the executive director of behavioral health at Verily, and a novel 115, which we'll talk about later, which is a novel addiction treatment program offering services in Dayton, Ohio. And last, we have Richard Pops, who's the chairman and chief executive officer of Alkermes. He joined Alkermes in 1991, and under his leadership, the organization has grown from a privately held company with 25 employees to an international publicly traded biopharmaceutical company with more than 2,000 employees. He serves on the board of directors for Neurocrine Biosciences and the board of Bio and the Pharmaceutical Research and Manufacturers of America. So with that, I'd like to start with you, Patrick. And I think starting today's discussion with your personal story, your own battle with addiction and mental illness, as well as your groundbreaking work on the federal parity law.
Thanks, Lynn, and so good to know you, Lynn, and thank you for doing all your work here at Alexandria Summit to bring people together. It's so much in my experience about building a campaign. I hear all of these great CVs, and there's so many distinguished scientists and molecular researchers and everything. And my scientific background is political science, and I like to think that that could be of service to the rest of science. And I appreciate the work you're doing to help coalesce people around advocacy. So the reason, when I wrote my book, A Common Struggle, people would say to me, well, what's so common about being a Kennedy? How can that be common? And I said, you got a point there, you know. But my family, like everyone else's, suffered from alcoholism, trauma, and addiction, and never talked about it. I mean, ever. The only time I talked to my dad and used the words alcoholism and addiction was when we were negotiating a unified bill between the House and the Senate, because my dad ended up being the primary sponsor due to the untimely death of Paul Wellstone, who you may recall was the champion of parity in the Senate and died tragically. My dad was chairman of the committee, so it fell on my dad to be the leader, much to my dad's chagrin, because he hated the whole idea that we would talk about mental health or addiction, or those words would be used in the same sentence as his name. So the bottom line is, what is common is that we never talked about it. My mom would come and go from the house to treatment centers. We'd never say a word. We'd very rarely know when she was leaving and when she came back. I'd play with my friends. Their mothers would come over and pick up my friends. I have to hide my mother so no one would see her inebriated. I had to witness all the taunts of my father, the words Chappaquiddick. I had to watch Saturday Night Lives making fun of my family and my dad. And I can tell you, neither my father or my mother, if they had had a choice, would have ever wanted to be subject to such brutality and critiques and attacks on their personhood, because to them and to my family, it felt like a political attack. We had to keep it secret. or God forbid someone would say it to impugn our family's integrity. And so I was absolutely so secret about it, I didn't even tell my psychiatrist, like what was going on in my family that was impacting my sense of self. And of course, because we don't get a driver's license on how to drive our brains, which is what I want for the world going forward, I want us to train to learn how to drive our counterproductive thinking patterns and drive into productive thinking patterns by knowing how to identify and intervene when those thoughts threaten to become behaviors. Because my recovery today from addiction is all about intervening early. But I never had any clue, and neither does anybody in America or around the world, how to learn about their own neuroliteracy. And the fact that education leaves out mental health, not only treatment, but social emotional learning and neuroliteracy is to me astounding in this day and age where more and more kids are struggling with these issues and they have no idea how to mediate their emotions and they have no idea that their amygdala is overriding their prefrontal cortex and that they're going like I did towards drugs and alcohol or other active behaviors of addiction. And the way I think of addiction, it is an underlying phenomenon. It's not opioid addiction. I just want to repeat that. There's no such thing as an opioid. You have addiction. I will never forget Matt Lauer asking me about my DWI in front of the United States Capitol 3 in the morning when I had totally blacked out thinking I had to go vote and almost ran over a Capitol police officer within inches of taking his life. So today, every time I get up in the morning, I already hit the jackpot. Like my life is made because I thankfully, by God's grace, I never ended up taking that Capitol police officer's life. And if it had been in the daytime, I would have run over a whole bunch of people. It was 3 in the morning. And Matt Lauer said to me, you know, they went through my previous 24 hours. Did I attend the, Hawk and Dove bar? Did I order rum and cokes at the Capitol reception? They were fixated on, was I drunk? Because that would make a greater narrative. When I said that I was blacked out on Ambien, they were like, that's not interesting to us. We want some more salacious stories. There's got to be drugs in there. And the irony is I was taking Ambien because I'd gone to Mayo for my opioid addiction and had withdrawn off opioids and then couldn't sleep. And so because the medical system is absolutely, ignorant of mental illness and addiction, and of course it's not in our EMRs and anything else, my doctor prescribed me Ambien, because of course that's not addictive, right? And so that's ironically how I got my driving under the influence was Ambien. And of course, I went on thinking like I had many, many times before that my treatment, my last day of treatment was going to be it. I was going to be finished and I was going to be better. And of course, our healthcare system ingrains that into our thinking that it's all episodic as opposed to a chronic illness, which is the bottom line. But I'm really honored to be part of this and looking forward to, joining my colleagues and friends about discussing these issues because they are so important to every family in America.
Thank you so much. And maybe now I'll just turn to you, Marty. In 2017, the deaths from opioids in the U.S. was 115 deaths per day. Today, that number is greater than 260 deaths per day. We at Alexandria partnered in 2017 with Verily and you with the mission to work towards reversing the course of this public health tragedy by creating a novel evidence and technology-based healthcare model. I think we have a couple of pictures of it, but I wanted to start. We've just celebrated our 2-year anniversary in October, and we're so proud of it, and maybe you can describe it.
Thanks, Lynn. I appreciate being here today, and thanks for the Galien Foundation for this wonderful forum today, and really great discussions so far this morning. So we did. We started with our partners, Verily and Alexandria, and 2 local hospitals in Dayton to build out a 5-acre campus that you see here. We did it pretty quickly. On this campus, we have every level of addiction care needed. So we have detox beds, we have inpatient residential beds, we have sober living beds. It's a total of 90 beds plus 12 crisis stabilization unit beds, which was, for the hospitals, really something that they were looking for. They said, we need help sort of decanting our emergency rooms, and we need somewhere else for these folks to go, that the minute they hit the door, you're not just going to start providing treatment, medical treatment, but those wraparound services that are so important for individuals as well. So this is a picture of our most recent opened building. This is a 58-bed facility. This is, for those of you that may know some of the terminology on this, this is what we call a 3.1 level of care. And so the 58 individuals that live here, and right now we're seeing that they're staying for about 60 days or so. Really the focus of the work, if you will, that happens in this building is to say, how do we help these folks enter back into community? So along with medical treatment, there is also work saying, do they need to get back to a job? How do we help them with workforce development? How do we help them repair some of the relationships that have been so damaged through their addiction and their challenges? And so you can see the inside of this building is, and again, big thanks to Alexandria, who designed this and built this with us. You can see that it really is respectful of individuals. We built this thinking of trauma-informed care principles, and so there's much of that throughout the building. And it's a place that, if you talk to any of our clients today, they will say the environment matters. It really does matter. But it's not just about the bricks and mortar. What we also set out to do 2 years ago, and we've just now seen about 4,000 patients, but is to say, what is it that technology can do as well? So how do we start to bring technology into this space, which really there hasn't been a lot of technological advances in the addiction space. And so Verily has partnered with us to bring in technology. So we have a clinician platform trying to help our clinicians become more efficient, trying to help our clinicians get the sort of real-time data that they need from their patients so that they can manage those patients in a very effective manner. We have a patient-facing app as well as a way to stay connected with our patients. Even when they leave our 5-acre ecosystem, how are we staying engaged with them? How do we make it easy for them to call their peer support specialist at 2 a.m. in the morning when they're really struggling? So really starting to advance technology in ways that, again, I don't think has been tested before. And then for me, what was so exciting is to say, we want to do all this in a way that we're building this learning health system. We've got now this beautiful real world evidence campus to say, how do we really learn about this? And how do we take this information that every day we're gathering data from our patients, we're gathering data from our clinicians, we're gathering data from our family members that may be involved. And how do we learn from that system? How do we collect it? How do we organize that data? And then how do we activate it? And I will tell you, one of the things, now that we're about 2 years into this, is that once we're now getting some of these data insights, if you will, and some of these learnings, it's hard to then put that back into real practice. The change management part of this, if you will, once we learn something, was much more difficult than I anticipated it would be. And I think part of that may be just because the behavioral health space that we live in has a bit been ignored, if you will, from many aspects. And so haven't had the technology, haven't had the rigor of some of the research and data coming back to say, okay, now here's what we know. How do we make changes for the betterment of our patients? So we wake up every day very passionate about the work that we're doing. We, the 5-acre campus that we have here in Dayton, again, we're serving, we had planned on seeing 1,000 patients our first year. We're 2 years in and we're almost at 4,000 patients. So the demand is certainly there. Like many through the pandemic, we also had to pivot a bit and say a bricks and mortar approach is not going to be the only way that we care for individuals. How do we start to use telehealth in effective ways as well? So again, having a partnership with a company like Verily, within 9 days, our software engineers built us a very robust and good telehealth system. And we're finding, again, through our data, that engagement via telehealth is really very effective. We can keep our patients really engaged in care in that way. So lots of work happening on the campus every day. Lynn and I were just talking, because of the pandemic, a lot of folks haven't been back on the campus, if you will, and it feels very different than where it was 2 years ago, because there are patients sort of around campus every day and getting good care.
And maybe just before we end, just to say, you know, this campus is all comers. So regardless of your economic status, regardless of your insurance status, you can come to 115 and you can be treated.
That's right.
Yeah. So maybe I'll go now to you, Richard. I saw a recent op-ed that you wrote in September for National Recovery Month, and your quote was that COVID has further deteriorated the situation, exposing gaps in addiction and mental health treatment systems that have made seeking and securing treatment a challenging and often insurmountable task for people living with addiction. At Alchemies, we make medicines for the treatment of mental health and addiction and focus on the real-world needs of patients and their families. So with that, maybe you can explain what you're doing at Alchemies.
I actually wrote that too, you know.
Yeah, it was good.
You know, when you get trained for media, they teach you that when you get asked a question on live TV, you don't actually have to answer it, because nobody really cares what the question is. So I don't have to actually react to anything Lynn said. So I'm not for the moment. I just want to say we've been on the same stage together before, and how great it is to be together. And Patrick, I just also want to note your honesty and your enthusiasm it's infectious, and it's critical, because there's a merry band of us that care a lot about this issue. And I can tell you, it's easy to get ground down, because we work really, really hard to deal with, as Patrick said, it's not opioid dependence, it's not opioid addiction, it's addiction writ large. It includes alcohol, it includes methamphetamine, it includes all kinds of various addictions. And all the collective intelligence, wisdom, brain power, technology that is represented by the biopharmaceutical industry, essentially none of it is being directed toward this problem. And it's a tragedy. Mm-hmm. Every new medicine for cancer in this country that gets approved is reimbursed at $15,000 to $20,000 a month, paid for by Medicare and paid for by Medicaid, to extend and preserve lives for durations measured often in months. We make medicines for serious mental illness and addiction. They're priced at a fraction of that, a 20th of that. We rebate 50% of it into the system in order to get onto the formulary, where formularies restrict access to it for patients, forcing them to fail multiple modalities that we know don't work. And only then do they have, every once in a while, access to our medicines. In a system that defines success as just simply getting some form of care, rather than reestablishing a productive, healthy, happy life. So the bar we've set for ourselves is so low in this country for the treatment of addiction. We tolerate failure every day. So when you hear the optimism of a Patrick and a Marty, and even myself, understand that it's against incredible odds. So I feel this is like my psychotherapy session right now, because I as a publicly traded biopharmaceutical company, what do your shareholders want? They want you to make expensive medicines that are highly profitable. And we've been super interested in taking care of people who need the care, people with serious mental illness and addiction, making medicines that we can put into a channel that we know is strapped for resources. So we have to price our medicines at addressable prices. But it frustrates me that all the power of the biopharmaceutical industry is not being directed towards problems that we know are solvable. We have the technology now and the tools. So it's inspiring. If you're inspired by that, think about that, because it's so easy to improve on what we're doing in treating serious mental illness and addiction in this country. It's not like we're at 80%, we're trying to get to 100%. We're at 0.8% trying to get to 2%. And even that would eliminate a tremendous amount of human suffering.
So thank you. And now I'm just going to go with all of us. Two questions. You know, one, and maybe it comes back to you, Patrick, really, you know, kind of leading on to what Richard said and defining what are those critical issues that we need to be, you know, uber focused on going forward with mental health and addiction. And then the second thing is something that I thought was so interesting in our prep talk when we discussed, why isn't this considered a national emergency? And what would that mean in terms of not only building awareness, but maybe more access to support and resources? So I'll start with you first.
Thanks. So appreciate that, Richard. Yesterday, the president released his opioid plan. And in that plan, there was no mention of coverage.
Exactly.
And in that plan, there was no mention of parity enforcement. Obviously, I'm partial because I wrote the law, but if you really want to change the system, you've got to put in place the financial incentives to bring care to everyone. So it's not a public charge through SAMHSA, which writes grants and block grants, as opposed to having it reimbursed like cancer, which is in the heart of your insurance. And because there's no enforcement of the parity law, one of the reasons why your colleagues in pharmaceuticals do not invest is because they know there isn't that high investment in making sure there's not this tremendous pre-authorization requirements, or fail first models, or medical necessity determination, or total lack of equality of pay for mental health clinicians, like you would not find in any other, because we as advocates are not powerful, and as such we don't impact the AMA's calculation of relative value unit. No, relative value. That's how our whole medical system determines what they pay for. We're the lowest on the totem pole for relative value unit. Whereas if you put money in this, not only do you improve everyone else's health care, because we all know the interrelationship between mental health and the rest of health care, but you would actually save so many of these lives. So anyway, it's astounding to me. The Medicare bill, the Congress, my colleagues on the Democratic side put forth a reform, thank God. Vision and dental are finally fixed because they were discriminated against. Did they say a thing about mental? No, because Medicare is the worst violator of the mental health parity law of any insurance system in the country, is the federal government. So I like taking on my friends at United and Anthem and Aetna, Cigna, Humana. I love going after the fact that when they don't comply, we want to hold them accountable. But let me just be frank, the federal government's not being held accountable. And when the President of the United States, who by all means is a friend, and he doesn't have a SAMHSA secretary today. Imagine that. In the peak of this crisis, does not have a point person on this crisis. Neither does he have an ONDCP director, Office of National Drug Control Policy. And the one that he has proposed has fully endorsed and supported medical marijuana, which if you want to know what the next Purdue Pharma is in terms of marketing of for-profit addictive medicine or drug, we're going to be saying the same thing about big marijuana as we said about, Purdue Pharma today. It's like we never learned from history. And my dad took on big tobacco because my sister Cara died of lung cancer at 51 and left 2 teenagers without a mother. Is because the tobacco industry targeted 13-year-old girls like my sister, got her hooked and she couldn't get free from it, and she got lung cancer and died. But of course it'll say that she had cancer, but it won't say that the reason she had cancer is because she had addiction, which drove the cancer. All I'm saying is that it's just like, I love hearing you, Richard, too, because the silence is deafening in this space, absolutely deafening. And we know, for example, we mentioned about reimbursement. Opioids get reimbursed still. We have products out like Exparel who can help reduce. They can't get reimbursed. Cytogel, pharmaceutical company with endomorphins trying to address pain treatment, can't get past clinical preclinical research because no biopharma is investing in them, even though they got research that the director of NIDA, Nora Volkow, who's a friend of mine, says is very sound science. You have a director of the NIH saying this could help reduce dramatically the opioid crisis, and no one's investing in it because for the same reason you just mentioned, Richard, they don't want to go through the hassle of bringing a drug to market to the tune of billions of dollars and not being able to bank on the drug getting reimbursed in the same way cancer, any other drug would get reimbursed. So that's, obviously I couldn't say much more than that, but
We love
I'm
you,
happy to
Patrick.
turn it over to someone else.
Yeah, clap. I think it does deserve that. Thank you so much. And maybe just, I'll kind of segue before I come back to you, Richard, on this, declaring a national emergency. One of the things about 115 that we talk a lot about is, the model and the sustainability of the model. I mean, obviously it depends on government funding, it depends on philanthropy, it depends on reimbursement. And I don't know if you have any comments on that, Marty, or just, some of the challenges there.
Yeah, certainly, and the payer issue is real, and I think one of the things that we are, sort of piloting, if you will, are many ways to take the data back to the payers and say, here's what we're seeing works and what doesn't work. But it is astounding the levels of care and some that we've created on this campus that payers just say, nope, we're not going to pay for that. Some of that is because of abuse in the past, and so this stigma that sort of, is far-reaching across all of this. We've really got to push on the stigma reduction, and I think now is the time coming somewhat out of the pandemic, if you will. The spotlight is on. It's on mental health. We need to take advantage of that and start to put campaigns together, I think, to say, let's talk about this. Let's have the conversations. I find once you open the door to have the conversations with folks, everybody's been affected by it in some way. Everybody knows, directly or indirectly, someone that's been affected by addiction. And so I think we should really step up and say, let's erase the stigma. Let's get a campaign out. Let's have this be the public health emergency that it really is.
And maybe just to add to one thing you didn't mention was why we chose Dayton.
Yeah, Dayton at the time in 2017-18, per capita had more overdose deaths than, I think it was the top 2 or 3 in the country as far as per capita of overdose deaths. So 2017 was a really high rate of overdose deaths, which we all thought, okay, 2017 will be the worst. We'll never see that again. As Lynn mentioned in her opening comments, 2020 is worse now. So clearly, our namesake comes from the fact that when we started this work, there were 115 individuals dying every day from an unintended overdose. We're moving in the wrong direction. In my home state alone, in Ohio, 15 people every day will lose their lives to an unintended overdose.
That we know of, because that's the problem.
That's right.
We don't have clean data. At the beginning of COVID, we couldn't suss out the difference between dying of COVID and what the comorbidities were, and let alone we didn't have a vaccine. Within a year, we're on to a vaccine, and we can count every life lost everywhere in the country on a daily basis. But our suicide statistics and overdose statistics are still a year old. And they're messy because every coroner tracks it differently, and it's astounding. If we want, quote, equal urgency to this, we ought to get the same data. And you all are always advocating for data because you know how much data can inform public policy. But today, we're reacting to 2019 data.
Hopkins tracker for COVID that we all, many of us
Daily.
daily track that. That's what we need.
And maybe, coming back, Richard, because I know you were the one who originally brought up this concept of, let's officially make this a national emergency, and what that could do in terms of, like I said, raising the awareness, access to money. So I'd like to just hear more your thoughts on that. I mean, one of the things I know that, you've said too, Patrick, is, kind of bringing back the lessons learned from the civil rights movement. How can we, kind of learn from that and take it forward as we sit today in this tragedy where the numbers are going in the wrong direction? I mean, greater than 260 deaths per day.
Well, I think in the wake of COVID, and COVID will end at some point, or at least reduce to a simmer, there's going to be this opportunity for another major public health initiative. So why not this? When you see the statistics of opioid overdose deaths or addiction overdose deaths, I mean, it's staggering. We're talking about hundreds of thousands. We're losing a generation of Americans silently without anybody really reacting to it. It's an opportunity for a number of different groups to come together in a really constructive way, a la what happened with the biopharmaceutical industry, public health officials, and government in COVID. Let's keep doing it. And it's difficult for those of you who haven't had any experience with it to understand how fragmented and broken and non-medicalized this system is. This isn't just first principles, Lynn. Why did you guys have to create 115? Why did it require Alexandria and Verily and Marty and community-spirited, philanthropic, humanistic people coming together to create this thing? You don't do that for cancer centers. You didn't have to build a cancer center. You know why? Because the hydraulics of the economy drive care in cancer.
That's right.
And those hydraulics are critical. You can not like that, but it's the truth. The reason why certain physicians behave certain ways is because there are financial hydraulics that drive behavior. And none of those exist in the treatment of serious mental illness and addiction. So it's a solvable problem. It's not mysterious, but we refuse to do it.
It's our call to action.
But to your point, Lynn, about the civil rights they did, NAACP had Thurgood Marshall. And what he would do is he'd look around the country, find what's the best case where I could win in one part of the country and that could create a new common law. So what we could do in mental health is, as we're enforcing parity in different states, for example, here in New York, you enforced parity and you got nationwide change in the way some of the payers did pre-authorization of MAT. For national payers was because of an AG in New York who enforced the law.
Sure.
And vice versa. We're getting, in the Witt versus United case where they substituted their own medical management criteria for generally accepted scientific criteria, which is really exhibit A for what we're fighting with parity, is that payers have just been so used to deploying their own proprietary. They actually pay for this criteria, which why would they pay for it if it's generally accepted? There's enough science out there, never happened in any other illness. In any event, if we could get some wins, then it starts to change the landscape, because when they were found in violation, I asked our insurance commissioner of Rhode Island to check on the United plan in Rhode Island. Lo and behold, same pattern and practice of discrimination in Northern California was happening in Northern Rhode Island. And so we informed the largest contract for them, which was state employees. And they said, we don't want an insurance plan covering our state employees that discriminates against their mental health, and they dropped United. Now, can you imagine the market pressure, Richard, if that happened in more places? And all it takes, Richard, is a handful of advocates in every state who are willing to go to their AG. And by the way, we already have the data. They don't have to make it up now. We've got the Millman report and all of this other data, 46 million payers claims data that shows all the payers are woefully deficient in complying with parity. But if you add some real faces with real stories going into Attorney General Narona's office in AG, I guarantee you he's going to say, okay, and he's going to get a case going. So all I'm saying, and that's the problem, we don't have an American Cancer Society where everybody's doing the pink ribbon and everyone's, putting their hand up and I'm a cancer fighter and all. Because of those that are surviving this illness, we're all anonymous. We're all stuck in church basements and we don't come out and bang the drums and say we're not going to tolerate the existing status quo. And that's on us because we can't appreciate that Bill W. testified in front of Congress, because a lot of people in 12-step recovery don't know that history and don't know it's part of their responsibility in recovery to open it up to others. But my point is that civil rights happen because people put themselves out on the line. And John Lewis went on that bus to desegregate, bus stations. And I guarantee you, if you tried to ask how many people would tell their real story about mental health and addiction, people wouldn't be willing to get on the bus to tell their story. I'm going to try to get 25 people in the next year, a third of which are well-known C-suite, CEOs, celebrities, to tell their stories, as well as people from other backgrounds. I'm not sure I'm going to be able to do it. And I have every chair of every department of psychiatry in this country helping me. And they all say, well, I'm not sure they're going to want to do that. Now, how are we going to fix this problem, Richard, if I can't get 20 people in this country who are willing to say, not just that I have a diagnosis, but here's how I deal with it at work, here's how I deal with it in my family, and here's why it's so difficult for me to get evidence-based treatment, to your points.
Well, let me just say, the CEOs have all kinds of other pathologies that are going to confuse all that. So I'll give you my Ohio story. Just one of, we could do this all day, but it just underscores the absurdity of this. We have an employee of ours, a woman, just an unbelievably tough, charismatic woman. 2 daughters, both became addicted to OxyContin in Ohio. One of them got on treatment, was doing well. The other one kept relapsing. She relapsed. She came home one day. The daughter had relapsed, was using heroin. Took her to the local treatment center. Local treatment center said, we can't accept her. We can't confirm that she's actually, impaired right now. She goes, what am I supposed to do? If I take her home, she's going to continue to use. She goes, go down the street to the bar, get her drunk. And if you get her drunk, we can admit her. And that's a true story. And so she went down, got her drunk, and she blew above the limit, and she could get into her inpatient treatment. This is happening every day, all across all 50 states. It's absurd. And so channel what Patrick is saying. This is a solvable problem.
And maybe, if you want to say a few words, you'll tell me if you don't, Richard, I know, or you'll say something else. But, the Matt, for those of you who don't know, medically assisted treatment is often very controversial. And I don't know if you want to make some comments on that. I mean, one of the problems, too, is just a lot of doctors are not able to prescribe the medicines that are needed.
It's become, MAT, medication-assisted treatment, it's become a political football. It's like, is medication controversial for the treatment of rheumatoid arthritis or cancer? No. Right. But the problem, it underscores the fact that this is not a medicalized condition. The way we treat addiction in the country is the government has been deeply involved in it through government policy as well as the criminal justice system. So we have methadone clinics all over the country. Those are administered by the government. They're not opioid treatment centers, they're methadone clinics. They dispense methadone. So people who believe in dispensing methadone, that's what they do. There are people who dispense buprenorphine. Many docs use buprenorphine. It's an effective drug. It's an important drug, but that's often for many of them. That's all they do, and so it's become tribal, and often, and this is a phrase you'll often hear, and it's absolutely true. The treatment that you get, it depends on what door you walk in, and that's not patient-focused and patient-centered, evidence-driven medicine. And that's another problem that we have in the whole treatment system.
Huge problem. And, I think, Marty, one thing that would be interesting for you to talk about is telehealth. I mean, telehealth is a great thing. We got pushed into it in COVID, and the great thing was a lot of the restrictions got loosened and lessened, during COVID. But now if we come out of COVID, what impact will that have? I mean, certainly we greatly benefited from telehealth at 115.
Right. Yeah, one of our sort of guiding principles when we stood this all up is to say we have our 5-acre campus, but how over time will we meet people where they are? And so telehealth has really helped us to sort of move in that direction. So we're working with one of the payers in Ohio right now where they've said, you know what, our members in rural Ohio are struggling. We're seeing higher rates of relapse. Is there something that you could help us with in rural Ohio? And so we have telehealth hubs, if you will, that are in primary care and federally qualified health center offices to say, you know, when someone comes in, if they are ready to get in treatment right then, they can access treatment right then with one of our providers. We have telehealth hubs in the public defender's office. So again, really looking at where are folks and when they're ready to get into treatment, how do we meet them where they are? Interestingly enough, our state medical board in July decided that they were going to go back to pre-pandemic regulations in the state of Ohio, meaning that the first visit needed to be in person. And so we fortunately had some of our own data to share to say, we can show you where a telephone visit, not effective at all, an in-person visit, pretty effective, but actually a telehealth visit with video and really a good outcome, if you will, with patients. We're saying that our patients are staying engaged 1.7 times longer with a telehealth visit. So we've had to do a lot of advocacy with the Ohio State Medical Board to say, hey, we really think if you're going to go back to these pre-pandemic regs, it's really going to hurt access to care and some of the effective outcomes that we're seeing. So fingers crossed, we hope at the November or the December board meeting that they are going to make that change and that it won't have to. Certainly, to have an in-person visit sometime perhaps within the first 3 to 6 months, that's okay. But we've seen many clients who, to get to a treatment facility is going to be 2 hours away. Our chief medical officer, has seen sort of a theme starting to come up with construction workers, and where construction workers are during their 30-minute lunch hour hopping on a telehealth visit from their truck on the construction site. And they'll say, if I didn't have this option, most centers are only open from 9 to 5, and so I'd have to take time off work, and would I be able to get there? We've had plenty of moms who say, because I now have a way to interact with my provider via telehealth, my kids have been home with school, they can still be here, I can be in a visit. So some of those barriers to care have been removed through this. But again, there are oftentimes then policy issues that we've got to make sure we're on top of and that we're fighting against.
As we continue to advocate, as I said when I opened up, the comorbidity of mental health and addiction is around 50%. And I actually was surprised it wasn't higher, but maybe it is and we just don't know. But, it's so important, the mental health and the mental health of our youth. And I know, Patrick, you're very passionate about this and, funding going towards and support, as we've seen the statistics that have come in. With the last one I saw was 54% of youth between, I think it was the ages of 11 and 17, frequent suicide, have thoughts about suicide, have thoughts about self-harm, or they do self-harm. And, that's part of this whole story as well. I don't know if you want to make a few words.
Yes, so, I've been putting every article about Facebook and Instagram in front of my 13-year-old daughter, who's on Twitch all the time and on social media, and who I have to hide the iPad from. And I don't even know technology, so my wife has to figure out all the apps to be able to check whether when she's in the bathroom she's not using technology. This is frightening. And I'm worried about my other 4 kids behind her. What kind of future do they have? And you've got everything coming at these kids. You've got the social media designed by neuroscience to hook these kids. And by the way, it's the kindling in the brain to set them up for addiction. So when I go back to saying it's not opioid, it's addiction, and you look for it in every kind of way. If you haven't heard the NPR study on Dopamine Nation, I commend it to you. It is fantastic because it basically talks about the underlying part of addiction. So it's gaming, it's pornography, it's gambling. So it's the internet games, all this stuff. And now we're going to throw marijuana on top of it. And it's like, you know, what are we expecting our future to look like? And we can address the systemic criminal justice problems by actually paying for addiction care and mental health. We can do pre-adjudication. We can address systemic racism through the way we administer justice. We don't have to use this, you know, Trojan horse that politicians are using. Legalization somehow is going to solve the problem of too many black and brown people in jail today. That's a farce. They're exploiting a very legitimate issue, which is the overrepresentation of minorities in the criminal justice system, for a for-profit motive, because there are 13 times more liquor stores in minority neighborhoods than there are in white neighborhoods. My neighborhood in Brigantine banned pot shops, but you can't do that in Pleasantville. They're going to be loaded with pot shops near where I live. And for people who are already on the margins economically to have to walk by those, you know, gummy bears, the elixirs with THC in it, vaping with THC, I am telling you, how do these kids stand a chance? And on top of the fact they don't know how to self-modulate, like my earlier point, to help cope with these stresses, so they're going to look for all these addictive industries that are going to make lots of money off of the death and despair of our young people. And it's criminal. It's criminal that we let. And the fact that this New York governor has just been bought and sold by big marijuana is a disgrace. Disgrace. And by the way, she's not alone. And a lot of my friends in the Democratic Party are all guilty of this, including your senator here in New York, Chuck Schumer, is pushing legalization. You know how long it took us to get out from underneath the thumb of big tobacco? 50 years, when we knew they were lying to us. And we're going to go right back down that road. And you'd think, you know, we got a mental health crisis and we got a drug that instigates psychosis, because that's what this really powerful THC does. It's not my 2% marijuana that I used to crack a Coke can and put some, you know, make a little pipe and hide behind my dorm and smoke when I was 14, 15. This stuff will blow the back of your brain out with the levels of THC in it. And you can eat it. I mean, it is just shocking to me that we're looking the other way. And corporate America is not standing up on this. It's going to impact everybody's ability to hold a job and of course, our healthcare system. And insurers are not standing up. You know, there's no major public health pushing back on this commercial marijuana. And you know, Marty, how many people, they come with opioid, but they also are addicted to alcohol. They're also addicted to marijuana. And if they're like me, they get out of treatment for one, and then they become addicted to another drug. Like I got cycled and spin dried because of our treatment system only looks at the drug as opposed to the underlying phenomena of addiction. I mean, to your point, Richard, we got so much that we need to do to fix this space. And if it weren't for you guys hosting forums to help bring some greater insight to this, we'd just really be stuck. So I appreciate what you're doing.
So important. Thank you. So maybe just in the kind of the remaining minutes, we'll come back around. I'm going to start with you, Richard. I'm going to ask a question, and then you can make a statement. But, you know, one of the things, too, we'll see if it addresses the question, but kind of coming back.
I won't be back next year, I don't think.
It's all right. You've been trained well. You know, coming back to kind of the national emergency and thinking about how we can access funding, I mean, funding from the federal government, funding from the opioid settlement when it comes due, it's probably really going to come down to a state level. And much like we saw with COVID, you know, the states are going to have strategies to really, and how they're going to deploy this money. So I don't know if you want to make a comment on that in your final minutes, or a comment on anything.
How about this? I will. So this may be a heretical concept. I don't think we need more money. If you go to the U.S. Senate or the U.S. Congress and you talk to people who've been instrumental in allocating massive amounts of federal funding into the states to solve this problem, they'll say, we've done our job. We've actually mobilized a lot of money. And there is a lot of money. What we don't have is money flowing into a functional treatment system. And that's because the treatment system is not, it's not based on evidence. Most of the treatment centers, I think over 50% of the treatment centers in states around the country don't have a physician involved. Last time we looked, under 5% of the treatment centers in America used all FDA-approved medicines in treating. So as I said before, they use one, and that's what they do. Nobody measures the outcomes. And as I said at the very outset, we haven't established a standard for care that says this is what our treatment objective can be, which is not just getting somebody on a drug or a replacement medicine or into a treatment program for 30 days. It's, can we reestablish their life and their happiness and make them functioning members of the community? I was in Kentucky, went to Kentucky for a roundtable meeting with business leaders on the opioid crisis. They pointed out that they'd lost 160,000 people in Kentucky, missing, just largely attributable to the opioid crisis. Most employers can no longer test for cannabis as a screen because everybody's on cannabis, and there's a huge vacuum in society now caused by the fact that people are just being lost to this crisis. There's plenty of money. So what people need to do is start saying, let's create opioid treatment centers or addiction treatment centers writ large, not methadone clinics or Suboxone clinics or Vivitrol clinics. Let's have opioid treatment centers like we have comprehensive cancer care centers. There's other social determinants of outcome, mental health benefits, employment, housing, all these other things. It's a holistic approach. It requires the community, but the resources are there, Lynn, and they just haven't been, it's so balkanized and so many people make so much money with the status quo that no one's really focusing on the nucleus, which is the patient outcome.
And I'm going to come next to you, Marty, because I think that sets you up really well, some of the things that Richard said. And when we think about 115, you know, we do think about measuring outcomes. It's technology-based, and we do hope that it will become a model that we can replicate or others can replicate throughout the country. So I don't know if you want to make a few parting words.
Yeah, I would just say, I think, you know, I don't want to sort of bring it down to something that sounds simple, but in many ways, when we think about the quadruple aim of healthcare, that's what we need to focus on in this space as well. So it's about being patient-centric. It's about getting them access to care. It's about reducing stigma. It's about harm reduction strategies, all of those sorts of things that are very patient-centric. It's about the evidence, and how do we look at the evidence broadly and start to say, you know, from a population standpoint, here's what the evidence is showing us, and not just on the medical side, but those social determinants of health. Let's really understand that evidence as well. We talk about sort of total cost of care with addiction, but I think there we really like to think of it as what we're now calling community tenure. What is it as far as folks getting back into the community? Are we getting them back to purpose? Are they getting back to a job? Are they not relapsing as much? But what is their community tenure? And then lastly, which we haven't really touched on yet, but that fourth sort of piece within the quadruple aim is around clinicians. And what are we doing around workforce? And, you know, I see every day how hard our clinicians are working on our campus, and how are we supporting them? What are the tools that they need? The burnout is rampant, especially coming out of the pandemic, and so what do we need to do with our clinicians? So I think of it sort of in that framework of the quadruple aim.
Thank you. And then you have the final comment, Patrick.
So on those clinicians, we need to have more black and brown clinicians, because vicarious trauma as a result of living through all the Emmett Tills, George Floyd's, just the multitude, just has re-traumatized every person of color in this country, and we don't have a mental health system that at all gets that, because it looks like white people and doesn't reflect the real underlying need of many minority communities where there's huge stigma, and we need to do a lot better job at addressing that. With technology, I'm excited by advanced directives. I gave my wife an advanced directive for me. You know, if I go back to the doc, which my doc, even though I've told them a million times I'm an addict, continues to prescribe me Percocets when I go into the ER with various lacerations and contusions because, you know, I'm with 5 kids and I'm always getting injured. I'm down there and I'm bleeding and getting sutured up. And I tell them, they said, are you allergic to anything? I said, yes, penicillin and opioids. And the nurses look at me like I'm talking a foreign language. What? Opioids? What happens to you? I said, I break out in handcuffs when I'm but the exciting thing is like my wife now has, I mean, who knows whether she could get real conservatorship or guardianship on me, but I have made it easier for her to get me help, and I've outlined it because I'm a person who needs that reinforcement. If more people got that kind of patient information, we'd be better off. If we used our cell phones, to Marty's point, and could recognize my voice throughout the day and could tell if I have bipolar, which I do, if not one. But, you know, we could tell when people are on the verge of a psychotic break based upon their voice, where their geolocation is. And if we do telehealth and the docs can see our faces, then we can do facial recognition, thanks to national security, can tell us when we're lying, which I did a lot of in therapy. And now my doc could get me right because he could say, Patrick, you're lying again, because it says so on the screen, because my face doesn't lie. The words coming out of my mouth may be lies. Like, imagine the opportunities to use technology as biomarkers to really help us treat these illnesses like A1C. And we have A1C corollaries in these metrics. And so technology has great possibilities, but we have to really advance those with the same urgency that we advance others. And advocates need to embrace and ask for this help, because otherwise they're all going to be squashed under privacy, which I get. But I don't need privacy. They're going to find out who I am in no time if I don't use technology to keep me well. And I'll be the last person who knows I'm in trouble. That's the nature of these illnesses. So technology could be really our friend, but we in advocacy need to be advocating for the right interventions on technology.
Well, thank you so much. I am truly so honored to be here with the three of you, and I look forward to many more discussions as we move forward, all of us with our collective voice. So please join me in thanking our guests, and thank you so much to the Galien